for uh, having this wonderful webinar, wherein, after attending to all these talks, it was a huge learning experience. And I would like to present on post-surgical dry eye. Now, as surgeons, when we do surgeries, the main concern that we have is to improve the visual acuity. So the visual outcome is something which is our main concern. And if the vision is good, and if we have done a refractive procedure, the flap is in proper position, no striae, no folds. If we have done a cataract surgery and the IOL is well centered, if we have done a retinal surgery, the retina is well attached, and if we have done a trabeculectomy, the IOP is normal and the bleb is well formed. So we are satisfied, we are happy about it. But the same thing doesn't happen with patients many times, and patients are very much keen, very much concerned about their comfort. And many times these patients after the surgery, in spite of a very good visual outcome, in spite of a very good anatomical outcome, some of these patients, they do have symptoms like irritation, redness, and foreign body sensation. And that is basically because of the post-surgical dry eye. That is a very important issue following these procedures. Now, these patients can have symptoms that can be very irritating and disabling, and that can affect the quantity and quality of vision. A case of a premium IOL cataract surgery done, poor ocular surface will have a poor quality of vision. Laser refractive procedure done, but the ocular surface is not very good and having dry eye, then the patient will not have a good quality of vision. And these patients, those patients who are at risk preoperatively and not properly evaluated, they have very severe dry eye and ocular surface disorder. The surgical procedure aggravates the dry eye. And it can be seen, as I said, after many surgeries. So corneal refractive surgery is something wherein post-operative dry eye has been reported very often. Now, before going actually into the causes of the dry eye in corneal refractive procedure, I'd just like to highlight the tear secretion neuronal loop. The cornea is supplied by the ophthalmic division of the trigeminal nerve, and the stimulus goes to the brain if there is some element of dryness. Now, the brain sends impulses to the lacrimal gland, and the gland secretes tears, and this is how it is maintained. But if the nerves which are sending the signals to the brain are transected, are damaged, in that situation, the whole loop gets affected, and there is a reduction in tear secretion. So in LASIK, wherein we create a flap, we cut the nerves, there is reduced corneal sensation, and there is decreased feedback to the lacrimal gland, and that is why there is reduced tear formation. Then there are other factors like there is subtle inflammation on the ocular surface, there can be drug toxicity, there can be pre-existing dry eye in these patients. Particularly some of these patients, some of these individuals who have undergone refractive procedure, they are on long-term contact lens, and that also affects the ocular surface many times. Now, there are other factors, there are many factors in LASIK which modifies the severity of dry eye or the ocular surface disorder. Like if you have a narrow hinge flap, then in that case, this means that you have cut more. In that case, you will cut more of nerves, and then the chance of dry eye is more, because it is directly related to the amount of denervation that you are doing. Then surface ablation cuts less of nerves, and I'll come to the studies that have shown that, and that is why the dry eye is less in comparison to LASIK. Initially, when femtosecond laser came, there was a lot of euphoria that probably it will have less of dry eye, but there are multiple studies now that have shown that the element of dry eye is seen in both, and it is not significantly different between the femtosecond laser or the microkeratome LASIK. Now, this is one interesting study which has done in vivo confocal microscopy, and have found out the subbasal corneal nerve plexus, which it was a long-term study. They studied the subbasal nerve plexus and found out that over a period of 10 years also after LASIK, the subbasal corneal nerve plexus did not completely recover to its preoperative pattern. And both main nerve density and the nerve branches density continue to be significantly lower compared with the virgin corneas after a mean 13-year follow-up. Although other parameters had recovered, but the nerve density was not as good as it was in a virgin cornea or preoperatively. Now, multiple studies have been done, and this is one study by Francisco et al., which is a review article which has evaluated most of the studies. It's a very interesting review article to read, and there are various studies that have been quoted in that. And in that, studies have shown that in PRK, what happens that you debride the epithelium and then you ablate the stroma. Now, in cornea, you have nerve plexus at 3 levels. One is at the deep stromal level, when the main nerve enters into the stroma, gets demyelinated after 1 millimeter of its entry into the cornea, and then forms nerve plexus in the stroma. And then the branches, they move up and they form the subbauman plexus. And then further the branches, they pierce the baumans and they form the subbasal, the epithelial plexus. Now in PRK, you debride the epithelium and you ablate. So what you damage is that most of the subbasal plexus and part of the subbauman's plexus. In LASIK, what you do is that the stromal and subbasal nerves are both severed during flap creation, except at the area where there is the hinge, and then subsequently the excimer laser will ablate the underlying stromal nerve plexus. So quite a significant amount of denervation is seen in LASIK. And it has been seen that less than 10% of original subbasal nerves remain in the operated cornea, and the subbasal nerves left in the flap may undergo a gradual degeneration in the early postoperative period. And in SMILE, what happens that the stromal nerves are damaged and the superficial plexus is very minimally affected, except in the area wherein you create a small pocket through which you extract the SMILE lenticule. And it has also been seen that the plexus is more dense in the peripheral part of the cornea. All these plexus are more dense in the peripheral part of the cornea in comparison to the central part. So studies have shown that hyperopic correction causes more nerve damage than the myopic ablation profile. And as far as nerve regeneration is concerned, in PRK, what happens is the epithelium and the most anterior stroma is removed. So the new neurites, they arise from the severed nerve endings, and they start forming very fast. The new nerve fibers start to emerge as early as 1 to 7 days. And in vivo confocal microscopy has shown that by 7 days, you start seeing the sprouts and the nerve re-innervation is quite significantly done by 3 months' time. However, the morphological and functional changes may still be present even up to 1 year time. In LASIK, what happens is that the nerve regeneration starts in the peripheral margin of the flap, and it moves in a centripetal direction towards the center of the cornea. Now, the denervation in LASIK is quite significant during the procedure, and it stays like that for nearly 2 to 3 months. And the regeneration starts. However, what happens that the regenerated nerves coming from the stroma below the LASIK interface, they are unable to cross and interconnect with the remaining nerves inside the flap. And the subbasal nerve density takes more time to recover in LASIK than in PRK. And studies have shown that even up to 5 years or 10 years after surgery, it has not returned to its pre-surgical values. Nerve fibers that do not penetrate in SMILE, what happens that you create a lenticule. So what happens that the area, the superficial plexus is mostly spared. Only in the area where you make a cut, the plexus is damaged. So it is mostly spared, and only the deeper stromal plexus is affected. So that is why the nerve damage is much less in SMILE, and that is why in the immediate post-op period, the amount of denervation is quite significantly less in comparison to LASIK. As you can see here, this is what the graph shows, and this is a study done for up to 5 years, and what you can see is that this PRK by 6 months time, it is almost 50%, it comes to normal. This is about the re-innervation, and by about 2 years time, it is close to normal, but it doesn't reach the normal value till 5 years. And in LASIK, even at the end of 5 years, it is quite significantly less than normal value. SMILE has a lesser follow-up. By the time this paper had come, it was only 6 months period, so it showed that more than 50%, about 60 to 70% of corneal innervation is done in SMILE after 6 months. And this is about the corneal sensitivity. Now, what happens that corneal re-innervation may not be complete, but the re-innervation may be adequate enough to improve the corneal sensitivity. And that is what happens in PRK, as you can see here, in 6 months time. In 6 months time, 3 to 6 months time, you can see here that the corneal sensitivity is quite normal. And that is why you require less lubrication in PRK than as you see in SMILE. And there are various studies which have shown that PRK has a better re-innervation than LASIK, and similarly SMILE has a better corneal nerve regeneration and better sensitivity than LASIK. And this is one survey that was conducted in patients dissatisfied because of LASIK, and 1 out of 5 individuals who were dissatisfied because of dry eye following LASIK. Now, apart from refractive procedure, corneal refractive procedure, even cataract surgery these days have shown, after we have attained the 6/6 and N6 vision, patients complain of irritation and watering and feeling of foreign body sensation. And there are various factors that are responsible for causing dry eye in cataract surgery. Like cataract patient population is older, has a high chance of meibomian gland dysfunction. Females are in the perimenopausal age group. They can be coexisting glaucoma, and they might be on anti-glaucoma medication. Then the lifestyle is such that you are always in air conditioners wherein the humidity is less, and so the dryness is increased. So all these factors, they lead to making the patient predisposed to dry eye. And once you have done a cataract surgery, you cut a little bit of nerves, you alter the corneal curvature, and the breakup is fast. And all these factors, particularly when we try to add many things like limbal relaxing incision, the corneal incision for astigmatism, etc., to make the uncorrected visual acuity 6/6, we end up cutting more nerves, and there is chance of dry eye. This is one study which has shown that the area wherein we make the incision, the corneal anesthesia is more in comparison to the cornea, which is distant away from the area of incision, and the breakup time showing a drop immediately after the surgery in comparison to the preoperative value, and even the goblet cell density has shown a decrease after cataract surgery. And this is one study which has shown that many of the patients in this study, they had shown symptoms related to dry eye following cataract surgery. Even after glaucoma surgery, a lot of patients, they do show symptoms of dry eye because you use antimitotic agent. There is risk of loss of limbal stem cells. There can be large bleb, which can cause rapid breakup. And even after retinal surgery, since the retina surgeon many times debride the epithelium, they cause conjunctival damage, goblets are damaged, and even these are prolonged surgeries. And this is one study which has shown that phototoxicity of the microscope light can cause damage to the ocular surface. And this is one study which has shown that in retinal surgery, when silicone oil was injected, there was more chance of dry eye. And of course, drug toxicity plays an important role. So all these factors can lead to occurrence of dry eye. As the previous speakers have very nicely mentioned about the management of dry eye, I will, due to paucity of time, I will go fast in this. And as we all know that the lubricants are the mainstay of treatment of dry eye, And an ideal polymer, as I had mentioned earlier, is yet to come, but a lot of polymers have been used as far as reduction of symptoms is concerned. Carboxymethylcellulose has been used for last so many years and has been found to be quite effective. And for the last couple of years, we have found that hyaluronic acid has come up with good outcome because of a high molecular weight. It stays longer on eye. It has long chains, twisting ribbon structure, and it can hold water, and it has a good mucoadhesive property, and it restores epithelial integrity, which was very well discussed by Dr. Nikhil, so I won't go into details of it, but hyaluronic acid is something about which most of the cornea surgeons are quite excited about. And there is always subtle inflammation, which can be a cause of dry eye, or because of dry eye, as Dr. Yokoi was mentioning, there can be increase in inflammation. Whatever it is, in order to reduce inflammation, we do require some anti-inflammatory in the form of topical steroid for some time, and cyclosporin has been found to be quite effective in these conditions. So in summary, dry eye can be seen quite commonly after ocular surgery, and all these ocular surgeries, the anterior segment surgeries as well as the posterior segment surgeries, they can cause damage to the ocular surface. The controllable factor in these is to reduce drug toxicity and to treat the preoperative dry eye so that it doesn't become very severe after the surgery. Preservative-free lubricants are the mainstay at this point of time, and if there is subtle surface inflammation, reduction of surface inflammation is to be done. But most importantly, all these patients have to be educated, they should be counseled and instructed about the risk of dry eye following any ocular surgery. Thank you very much for your patient listening.